Good afternoon and welcome live audience and those that are joining us via Polycom and through our website. It is my pleasure to introduce a colleague and dear friend of mine, Dr. Juanita Lozano Pineda. She is an assistant professor for the Department of Comprehensive Dentistry at the University of Texas Health Science Center San Antonio Dental School. She is a native of Brownsville, Texas, received an undergraduate degree in biology from St. Mary's University, a Doctor of Dental Surgery degree from the University of Texas Health Science Center in San Antonio Dental School, and a master's in public health from the University of Texas at Houston School of Public Health. Dr. Lozano Pineda is the course director for clinical preventive dentistry and director of the outreach programs for South Texas extramural rotations to federally qualified community health centers along the U.S.-Mexico border, and also mentors dental students with community service learning projects within San Antonio and at Mercy Ministries of Laredo. She was co-PI for a Health Resources and Services Administration sponsored U.S.-Mexico Border Health Center of Excellence Consortium, whose focus is to help address the health and workforce needs of the border communities. She has an interest in oral disease prevention, health promotion, and the oral health disparities of Texans, particularly the primarily Hispanic populations along the U.S.-Mexico border region. She has participated in various clinical research activities, including a pilot study comparing caries prevalence among asthmatic children, and was a co-investigator in the NIH xylitol adult caries trial. Dr. Lozano Pineda is also a practitioner investigator for the Pearl Dental Practice-Based Research Network and works closely with Pearl dental practitioners from federally qualified community health centers. Please join me in welcoming Dr. Lozano Pineda.
Okay, good afternoon. Welcome to people that are at a distance. We're going to talk about oral health findings of the Hispanic population and some of the oral systemic links that pertain to diseases that Hispanic population has in our areas. First of all, an overview of oral disease. It is a burden among the Hispanic population. The overview, we're going to review that. We're going to review the oral health and how that pertains to general health and what the consequences are in the oral cavity from treatment and general therapies that are given at the systemic level, and then how there's an oral systemic disease connection. And then at the very end, we'll talk about the barriers to accessing dental care. Oral disease is a common problem that includes cavities, periodontal disease, oral infection, salivary gland dysfunction, and oral cancer. Of these, dental caries is the most common at all age groups, and it is the most common disease among children. We're looking at early childhood caries for children that are, from year 1 through year 3 or 4 that can develop caries at a very rapid rate due to how they ingest the milk. Baby bottle tooth decay is what it used to be called. Now we call it early childhood caries. Dental caries in the adult population, periodontal gum disease that, if untreated, can lead to tooth loss. And then oral cancer lesions. Primarily, squamous cell carcinoma is a very common one that affects the oral cavity. Children from lower income families often do not receive the timely care that they should have, and because of that, they have untreated tooth decay, and they're more likely to suffer from these problems. The Surgeon General report, Oral Health in America, a report of the Surgeon General, reported that families that live below federal poverty level are the ones that experience the most problems with dental decay, and that these people are also economically, they're not economically stable to provide the services for their children. And what the children experience is more likely to be untreated. The highest rates, we hear a lot about how there has been a lot of advances in preventing oral disease, but there are still high rates that are prevalent, and these are prevalent among the indigent and minority populations, especially along the U.S.-Mexico border. So what we end up having is that about 20% of the population has 80% of the disease. And most of them would seek care in a public sector setting or not at all because of barriers that they may have. And these are some of the lesions that we may see from individuals that do not have access to care. They can't afford it, they can't access it, so the disease becomes overwhelming. The CDC Center for Health Statistics data indicates that minorities, both adults and children, have more untreated caries. And a 1988-2004 NHANES survey indicates that the prevalence of untreated tooth decay in children ages between 6 and 19 was 22.9%, but it's important to note that as we look at it through ethnicity, 30.6% was among Mexican American children, so you can see where that is higher. This particular table illustrates that even though, let's say from ages 2 to 5 year old, if we look at the Mexican American children with Hispanic origin, we find that the trend has, even though the trend has decreased through the years as far as the amount of decay, that segment of the population still has the highest levels of untreated decay through 1988 and 94 and through 2001 and 2004. We have, for the 6 to 19-year-olds, we have the same situation where we look at ethnicity, the Mexican American is the one that has the highest prevalence of disease. And as we look a little further down, the poverty level also impacts that. The higher the poverty level, the higher the burden of disease. And this is just a snapshot of the Texas children. Children ages 2 to 4, when we compare the children, they had 29% caries, untreated caries, compared to the U.S. average of 20%. The healthy people 2000 target is 9%. And then children that were ages 6 to 8, we can see how much higher, 44% in Texas compared to what the national average was of 26%. Periodontal disease is another problem that affects much of our population. Bacteria that works its way under the gum destroys the gum and the bones, and the teeth become loose, chewing becomes difficult, and the teeth may have to be extracted. Oral cancer is the other issue, and what are the risk factors for oral cancer? What we have is excessive alcohol consumption can increase the risk for oral cancer. Tobacco use in any form, whether it's a cigarette, pipes, chewing, snuff, etc., it's all is associated with an increased incidence of oral cancer. And each year, over 7,000 people die from oral and pharyngeal cancers. About 30,000 new cases of oral cancer are diagnosed annually. Now, how do we have a connection between oral systemic disease, oral findings, and systemic disease? We have had studies that have identified it in diabetes, in cardiovascular disease, in pregnancy complications, and in pneumonia. But first, what we'll do is look at some of the findings that we see in the oral cavity as a result of having some type of medical treatment. Okay, HIV oral lesions for individuals that have HIV. Oftentimes, the lesions are one of the first things that gets manifested in the oral cavity. So this is something where an individual that is having a problem with their mouth may present to the dentist to have this evaluated before they go to the physician. And then that can be something where, depending on different circumstances that would help us diagnose the differential diagnosis, we can work our way in and find out whether or not it's related to HIV. Sexually transmitted HP16 virus, the human papillomavirus, this is more recent findings that there has been established that the cause of the number of oropharyngeal cancers are related to the HP virus. So this is something that is up and coming as far as studies that are being done. We're trying to figure out why is it that some people develop oral cancer if they don't smoke, if they don't drink alcohol. And some of these are going back to the fact that it's related to HP16 virus. So we're going to be seeing more of those studies coming on to make sure that we follow through and see whether or not it indeed is associated and a causal effect. These are some of the lesions that will present for patients that have HIV that present in the mouth. The most common ones that include oral warts, and this one right here is an example of an oral wart on the labial mucosa, fever blisters, hairy leukoplakia, where the tongue gets some of the leukoplakia on it, and it's not just on the buccal mucosa. And you also have oral candidiasis that can be erythematous, or it can be the pseudomembranous, where it, you can just kind of peel it off. And then there's also aphthous ulcers, the little fever blisters and stuff, canker sores that individuals can get. People with HIV may also experience a dry mouth. And the fact that you have a decreased saliva flow increases the risk for tooth decay. It makes it difficult to chew and to eat because certain foods can't be swallowed as effectively without the lubrication of the saliva. And some patients can even have difficulty talking. But what happens when you don't have the buffering benefit of the saliva is that anything that is acidic in the oral environment, like the plaque, the bacteria produces acid. Any soda that you drink that's acidic contains acid. Any sugar, carbohydrates that you ingest that can get broken down to sugars and eventually acid. If you don't have the saliva to buffer that acidity, you increase the risk for the demineralization and for the cavities to happen, for the gingiva to get irritated, and for periodontal disease to advance. So it's a big problem. Xerostomia is a big problem, and we find it in many systemic diseases and therapies of the systemic diseases. This right here, you can't see it very well, but hopefully you can when it gets viewed. These are just a more complete list of the oral lesions that are associated with HIV. And they're basically fungal with candidiasis, like we mentioned earlier. They can be pseudomembranous or erythematous. You have angular cheilitis at the corners of the mouth, where sometimes some of the candida can irritate the tissues, and when the patients open wide or if they have dentures, and it can be a problem because they get little tears at the angle of the jaw and at the angle of the mouth. And then as those heal, they scar. And as it scars, it starts limiting the opening more. Every time that they open wide, they re-injure it. But the candida irritates that, and it can be a problem. Histoplasmosis, cryptococcosis. There's also viral, like the herpes simplex, herpes zoster, the human papilloma lesions, hairy leukoplakia. We have bacterial lesions that pertain to the gingival erythema that I was talking about, where the gums just get very irritated. Necrotizing ulcerative periodontitis, what that is just a very aggressive form of periodontal disease that is unfortunately common when you're immunosuppressed, because you just can't fight off the bacteria the same way. So it's very destructive. The gums get very inflamed, the bone gets damaged. We also have neoplastic Kaposi sarcoma is a very common cancer in our HIV patients, and also non-Hodgkin's lymphoma. Other things would just be recurrent aphthous ulcers. They just keep coming back because of the fact that these individuals are immunocompromised. Immunothrombocytopenic purpura, and then HIV salivary gland disease. And this is where they end up getting the xerostomia, where they end up not producing the saliva that's needed. So again, here's a dry mouth. The tongue will look very red because it's irritated and it's dry. Things are very sticky. Things for us as dentists, like when we put a mirror in there, there's just no lubrication in there in the mouth. And sometimes when we ask patients to give us a saliva sample to try and measure the amount of saliva that the parotid glands and submandibular glands are producing, they just can't give us anything. There's nothing. So you can see where it can be very uncomfortable for people that wear dentures. It can be uncomfortable for people to eat certain foods, certain dry foods, because they just can't lubricate it. And it's important for patients to understand that they have this problem, because if they go in there and try and treat it by drinking coffee, then the caffeine dries you up even more. So it's important to educate patients about what they need to drink or how they can manage their xerostomia. Avoiding acidic things and drinking water is the best way to do it. Chewing sugar-free gum can also help stimulate some saliva flow. But this xerostomia is also a side effect for many of the prescriptions that we give, many of the prescriptions that physicians prescribe. If you're treating somebody for depression, if you're treating somebody for hypertension with diuretics, if you're treating somebody with steroids, antihistamines, if we think about just how many different medications can have a side effect of dryness and decreasing lubrication, it affects the salivary gland. So we also see this problem with many of our elderly populations that are on various medications. Down the road, they end up causing a problem. Some of our diabetic patients can also end up, because of the neuropathy, can end up having some damage to the innervation to the salivary glands and also decrease saliva production. Another area where we see that there's oral manifestations and oral implications from therapy is with asthmatic patients, because again, if we think about the type of medications that are being prescribed, we're giving steroids, we're giving the bronchodilator. A lot of times asthma is associated with allergies, so there's an antihistamine that is prescribed. So we find that many of the patients that have asthma therapy end up having xerostomia. They also have an increased incidence of candidiasis because of the steroids that they use on the inhaler, and increased caries as we combine these things. So it's important that you instruct patients to rinse their mouth with water after they use the inhaler, because there is lactose, there's different sugars and steroids in these inhalers, and that little dust that stays in there, as it gets mixed up with the saliva and stuff, can end up just having a more acidic environment, and that in turn increases the risk for caries. Okay, so and what we have here on this table, it shows that children with asthma, we don't have too many that are, when we look at other races, other ethnicities, the Hispanic population has 7.1% when we look at it as a whole, and this was in 2007. This is a study that I was involved in, a pilot study, where what we did was wanting to find out whether or not the treatment of asthma increased the risk for caries, whether or not we would find more cavities present in children. And the way that we set up the study, because there's different things that can increase your risk for cavities. It can be your diet, it can be whether or not you brush your teeth, it can be your socioeconomic status, whether or not you use fluoride, all kinds of stuff, right? So what we did with this particular study is that we compared siblings. We compared asthmatic and non-asthmatic children within 2 years of age, as close as possible, so that we could find out. We figured at that point the diet is going to be similar, maybe oral hygiene will be similar, because the parents are the ones that kind of help out at that point. So we were trying to limit the other variables that would also increase cavity presence. And we found that as you looked at all those other variables, making sure that they were minimized between the siblings, we still saw a greater incidence of cavities and incipient lesions on the children that were receiving asthma therapy versus their sibling that was not. There have been other studies and other papers that have been written on this. There's one that's going to be coming out in the International Journal of Pediatric Dentistry. I reviewed an article that's going to be published, and it has a lot of additional information on this. But what we can have here, as I mentioned earlier, the incidence of asthma appears to be lower on the Hispanic population than on the Black population, but if we dig in a little closer, we can see that if you're in a community that's treating patients that come from Puerto Rico, you may have a population that has a much higher incidence of asthma. Okay, so making sure that if you're treating this population, that you're giving them the instruction to rinse out with water and to increase water intake and to decrease sweets, because they are at a greater risk for cavities. Now, cancer treatment also has implications in the oral cavity. More than a third of the people treated for cancer develop oral complications. These may interfere with cancer treatment and diminish the patient's quality of life, because it affects their ability to eat. A lot of times they get that stomatitis, and they have to rinse out with like antimicrobial rinses and stuff, so to minimize some of these problems as they're undergoing the therapy for cancer. Head and neck radiation, chemotherapy, and blood marrow transplantations can cause oral complications ranging from dry mouth to life-threatening infections. Again, if you have radiation to the head and neck area and you give radiation to the salivary gland area, they're gone. They're not going to produce saliva anymore, and you have a problem. If you radiate the jaw for any kind of cancer that's in the head and neck area, and then you have an extraction done after that, there's a risk that bone will not heal, osteoradionecrosis. So it's important that patients that are going to have any type of cancer therapy have an oral evaluation before they're going to start this type of treatment, so that anything that needs to be extracted gets extracted before they start with radiation, because then things that cause a problem right after that, they'll have difficulty healing. So having an evaluation to get that taken care of ahead of time should be the standard of care. Biphosphonate therapy is another thing that can have oral manifestations. We're finding growing evidence here that's showing that patients that are treated with biphosphonates have the potential risk to develop necrosis of the jaw. What happens is that, well, first of all, the first case was observed and reported in 2003. So even though it's been, 8-9 years, at first we just didn't know what was going on. Why this person did not receive radiation therapy? Why is their extraction site not healing? Why is the bone exposed? But what's happening here is that the jaw, what we're calling it is biphosphonate-related osteonecrosis of the jaw. Okay, and as we continue to do studies and further investigations with this, at first we thought, okay, is it people that are taking oral meds? Is it people that are taking IV meds? Is it related to the length of how long they've been taking this oral medication? Has it been more than a year, more than 10 years? What is it that's increasing the risk for this to happen? And as the studies have continued, it seems that the greatest risk to develop this particular problem is for patients that have had IV biphosphonates given, or that have had oral for a very long time. But it's still important, once again, that if there's any type of dental problems, any type of tooth that needs to be extracted, that be done before this type of therapy happens, that it gets started. Because once it gets started, if you think about how biphosphonates work for osteoporosis and for everything, they affect the regeneration of bone and the destruction of bone. Just the way that it slows down the destruction of bone so that osteoporosis doesn't advance, it can also affect the regeneration of it from trauma that can happen after you have an extraction site. So it manifests as exposed non-vital bone involving maxillofacial structures, and it's thought to be caused by trauma to the area from having a tooth removed, and there's limited capacity for the bone to heal because of the effects of the medications. So these are just a couple of samples. You go in there, you remove a tooth, You expect the patient to come back a week later and for things to be closed up. But this is what happens instead. Okay. Another thing that affects the oral cavity is addiction. And we have a couple of addiction problems. One has to deal with being addicted to tobacco. And we have 43.4 million people, about 19.8% of the U.S. population that smokes as of 2008. And of these, 13% are Hispanic. Half of the cases of severe gum disease in the United States are a result of cigarette smoking. So what this means is that people brush their teeth well. It's not because they're not brushing, it's not because they're not doing their part, but they still have periodontal disease. And the finding is that even though you're not diabetic, even though you don't have all these other problems, if you smoke, you can still have periodontal disease. 3 times as many smokers as people who have never smoked have gum disease. So there's a discrepancy there. And this just shows how, if we look here, the people that are smokers are in the dark blue, and the people that have never smoked are green, and the former smokers are light blue. So how is your overall oral health? If it's going to be very good, generally you have never smoked. Or if it's going to be good. As it becomes fair and poor, more than likely you're a current smoker. And that affects your oral health. And if you've never smoked, you're going to have be less likely to have poor oral health. Smokeless tobacco is also a problem because the individuals position the tobacco right next to the gum line. All those chemicals irritate the tissue, irritate the gum, and they start forming some leukoplakia, but the gingiva starts to recede, and because it wants to pull away from all that irritation. There's some bone loss, some cavities that can form. There's also leukoplakia, as we can see right here, the keratinized tissue reacting to all those chemicals. And then cancer, eventually oral cancer and pharyngeal cancer that can happen from this type of tobacco. But in general, 90% of oral cancer deaths are attributed to smoking. Again, this is oral cancer that we're talking about. And a lot of times I think the public listens to commercials and reads boxes and stuff, and a lot of times we think about cardiovascular effects of smoking. We think about pulmonary effects, maybe lung cancer, but we don't, as a dentist, we think about oral cancer, but this is just to give you an idea of how related it is to smoking, that 90% of the oral cancer.
That's smoking, not just overall tobacco use?
Well, this would be this is for smoking, yeah. It also has a negative effect on the subgingival flora. Again, the bacteria that is under the gum line, it may affect the good one because we have a balance. Because of this, as you lose bone, it can loosen and shift the teeth. It increases the formation of calculus or tartar. There's reduced wound healing. When we have patients that smoke and they're interested in having periodontal surgery or implants, we really advise them to discontinue smoking because the odds of that being successful is decreased because of the fact that it delays healing. And there's also a suppressed immune response. So with periodontal disease, it promotes periodontal disease by depressing the polymorphonucleosides, by accelerating bone loss, and by increasing the calculus. So these things combined is what negatively impacts periodontal disease. And there's enough evidence that exists to infer a causal relationship between smoking and periodontitis. It's not just we think, no, there's enough evidence there. Other effects of smoking, discoloring the teeth, tooth abrasion, because with the chemicals that are there, then when you brush your teeth, the acidity just makes it easier for them to get abraded. Mouth sores, hairy tongue, bad breath, and an altered and impaired sense of taste and smell. Another form of addiction is methamphetamine abuse. We see a lot of this. More common oral findings for individuals that abuse this drug, they have poor oral hygiene, and this relates to the fact that they're overpowered by their abuse, by their addiction. They neglect themselves as this addiction takes over. So they have poor oral hygiene. They also have xerostomia, and this may be related to the medication, to the methamphetamines. They have rampant caries. I mean, when we see an individual like that, we just say, okay, this is meth mouth. That's what we call it in dentistry, meth mouth. And it also causes excessive tooth wear. And these are a couple of samples of extreme cases, but not uncommon cases. We see this a lot. And again, think of the individual that may be addicted to meth mouth. It's not only the poor. There are people of all socioeconomic levels that try this drug to stay alert or whatever, and then they get hooked on it, and the next thing you know, this thing controls them. We have a program in San Antonio where our students rotate and do a week of clinical care at Haven for Hope. Haven for Hope is a facility for the homeless population in San Antonio. It's a transformational facility where individuals that go, that seek care and become members are able to access care for mental health, for medical care, for anything from learning how to training with computer skills, how to fill out a resume. There's people that hairstylists that volunteer and also go and do services there. So there's about over 72 partners from the San Antonio community that provide care. It's a very large complex, and individuals that are homeless have the option to enter into that environment and seek care, and they can start off at Prospect Court, which is a court for individuals that are still not comfortable living inside. They prefer to live outside. They can come in there at the end of the day, have a meal, and sleep in an area that is safe so that they're not out in the street, because they are at a danger. They are at a danger if they're out in the street. So they're able to find a place to come and spend the night and have meals, and then they're off during the day. Out they go. But these individuals are not ready to transform yet. So many of the individuals that present have addiction problems. As they're ready to transform, they become members. And when they become members is when they have access to all these other services. The dental care that we provide is primarily to the members, and urgent care is provided to those that are in Prospect Court. If they're having a toothache, if they're having a problem, we treat them for that. And once they're ready to make the transformation to seek the therapy that they need, then everything else is provided. Comprehensive care is provided for these individuals. But many of these individuals, when we look at their dental history, at their radiographs and stuff, you can tell that at one time they had dental care. They have crowns, they have root canals. They had a job that provided insurance. They were able to get the care that they needed. And whether it's the economy, whether, some have lost their homes because of the loss of a job. Others have lost their homes because of addiction. They just let it all go. Okay. So it's a good program, but unfortunately we see a lot of this type of disease, and we have about over 50% of that population that also smokes. So there's a lot of need in that population. Now, how does oral health impact general health? We talked about how the treatment of general health impacts the oral tissues. Now, how does oral disease impact general health? What we have, oral health complications not only reflect general health conditions, but also exacerbate them. okay? Infections that begin in the mouth can travel throughout the body. We talked a little bit about periodontal disease and how it can happen and what can make it worse. But what we're finding is that periodontal bacteria have been found in samples removed from brain abscesses, from pulmonary tissue, and from cardiovascular tissue. So that bacteria makes its way to other areas. Periodontal disease has been associated with adverse pregnancy outcomes, with respiratory disease, and with diabetes. Epidemiological studies show an association between periodontitis and atherosclerosis, stroke, respiratory disease, and diabetes. So if we think about how many people present with that type of problem, some of it can be aggravated if there's problems in the mouth. The risk for these systemic diseases in patients with periodontitis is 1.5 to 2-fold higher than the individual without periodontitis. So that's the type of impact that it has. There's a significant association between tooth loss and periodontal disease and carotid artery plaque formation, as they've done some of these studies. The implications of the proposed linkages are the harmful effects of the circulating microbial, the bacteria that's circulating, and the host inflammatory cytokines that are on the vascular, lung, and heart tissue. So if we think about how these inflammatory cytokines impact those tissues, the inflammation in the mouth elevates those cytokines, and then it can impact these other tissues. These potent molecules may also cross the placenta or initiate a cascade of events that affect the uterus or the developing fetus. The complications of diabetes mellitus: periodontal disease, salivary dysfunction, like we talked about, because of the neuropathy that can affect the salivary glands, and then dental caries and tooth loss because of the xerostomia. This is a diabetic patient that has problems. Okay. Another problem that we see in diabetic patients, oral fungal and bacterial infections, delayed wound healing, mucosal neurosensory disorders, and the prevalence and chance of developing oral mucosal lesions. It's higher in the diabetic patient compared to the healthy individual. This is a patient that does not have a lot of bacteria, but there's still a little abscess up here. And this can be related to the need of a root canal more than the periodontal disease. But this particular abscess is a form of inflammation that releases those cytokines in the system that can then impact the other tissues. There's been talk of considering the periodontium as the sixth complication of diabetes, because we know how it affects the peripheral blood vessels, how it affects the feet, the kidneys, the eye, the central blood vessels, and the nerves. But now we also have to consider how it affects the bone level and the gum of the individual. Clinical trials and case studies show a combination of mechanical therapy. In other words, when we do scaling and root planing and we remove the tartar and the bacteria from the gums and provide systemic tetracycline therapy, this has provided a short-term decrease in the hemoglobin A1C of some patients. There was a study that was done where they did that. They measured the hemoglobin A1C before, they cleaned their teeth, they gave them tetracycline, and then the hemoglobin A1C level improved. There have also been studies where they just mechanically removed the irritants and gave the tetracycline, and this improved the periodontal health in most of the diabetic patients. But the biggest improvement was seen in the individuals that had the severe periodontal disease. Okay, their glycemic control improved better if they were poorly controlled. They had severe periodontal disease after they had their teeth cleaned, and they received the tetracycline. They were the ones that had the most improvement, probably because the inflammatory cytokines were at the highest level on these individuals when they're uncontrolled. and they have a lot of inflammation. So the biggest impact was seen on those individuals. So we're saying, okay, does diabetes, there's this thing that goes on back and forth between diabetes and the worse your diabetes is, if you're not controlled, the greater the chance of you losing bone around your teeth because of the uncontrolled diabetes. But then the greater the irritants and the inflammation in the mouth, the more difficult it is for you to control your diabetes. So it kind of goes back and forth. So we're saying, well, if you clean the teeth, will that lead to glycemic control or improved glycemic control? So can we look, the way to kind of rationalize this is that we have acute bacterial infections that increase insulin resistance and they aggravate the glycemic control. So if you have insulin resistant and altered glucose metabolism persists for days and months after the resolution. So you may treat an infection, but it takes a while for those little things to settle down, okay? So a possible mechanism by which a periodontal infection can worsen glycemic control would be, let's say that you have a gram infection results in increased resistance. If you do periotherapy, then that is going to decrease the bacterial load, which decreases the inflammation, which increases insulin sensitivity, which could increase glycemic control. So that's kind of like the proposed mechanism as to how it can relate to each other. Now, periodontal disease there's a disparity in the incidence and severity of periodontal disease in lower socioeconomic and racial ethnic minorities. Plus, individuals in these groups are at a greater risk for tooth loss and grave systemic consequences like stroke and atherosclerosis. So, it doesn't help. This is some of the periodontal disease that we observed with a program that we did at colonias in the Webb County area. A lot of these individuals did not have dental care, and they were presenting to the mobile van for dental care. But you can see where there was a lot of periodontal disease, and this is just an X-ray that correlates to this particular. This is what it looks like clinically, and then this is what it looks like radiographically. The bone is destroyed all the way around the teeth, so there's all kinds of infection and inflammation that is present in the bone around that tooth that can be releasing all kinds of inflammatory cytokines that can make it difficult to control problems, or they can aggravate situations. But there's barriers to dental health care that make it difficult for people to access the care that they need, despite us knowing that these things are related and that this impacts general health, and that general health impacts the oral cavity. And the barriers are financial, cultural, and the infrastructure that's available. We don't have enough insurance with some individuals, and those that are poor are the ones that have the biggest burden of disease. There may be a language barrier, and there may be, you may live in a county that does not have a dentist. We have over 40 counties in Texas that do not have a dentist. Some of them are rural, but that's still excuse me, unacceptable. The lack of access to oral health care frequently affects those of lower socioeconomic level. They experience more dental decay that remains untreated, like we mentioned earlier. There's inadequate dental care across the access may be attributed to the exclusion that's, again, economic, geography, depending on where you live, the age, because sometimes the elderly have a more difficult time accessing it because they're uninsured, the race, and the ethnicity, and this has to do more with language barriers. If we look at the uninsured in Texas, we have a report that was called Texas on the Brink. Did anybody read that one, Texas on the Brink? It was a summary by a legislative study group. This was in February 2011. 28% or 6.1 million of the population is uninsured. That's the largest share of uninsured in the nation. 16.3% of the children were uninsured in 2009 compared to 8.6% nationally. So you can see the big difference there. 63% of adults between the ages of 19 and 64 living in poverty do not have health insurance. And 59% of the Hispanics under age 65 had no health insurance, compared with 11% of blacks and 26% of whites. So you can see the big difference. But what we have to look at is that for every medically uninsured Texan, there are 2.5 to 3 Texans without dental insurance. These numbers are for health insurance. So for dental, it's at least twice as bad. The financial barrier is another thing. In Texas, Medicaid and CHIP only cover individuals until age 21. There's no dental coverage once you turn 21. And the closer you get to 21, the less likely you are to have the coverage. Medicare covers only very selected dental care for our elderly. It has to be emergency care that gets delivered. Like if they have an abscess, they may cover it, and then you have to go through all this paperwork and stuff to get it done. Title V and COPC funding is limited. There's a high uninsured and underinsured rate in Texas. So what this means is that we just can't access the care that we need. And in the border, these barriers are even worse because we don't have enough doctors down there. We don't have enough dentists down there. We have a lot of poverty. We have a lot of language barriers. Now, if we look at the oral health status of children in rural areas, we can see where language barrier is the issue. Hispanic children whose families primarily speak Spanish were the least likely to be in excellent or very good oral health, regardless of the location. And if we look right here in the middle, these are the Hispanic Spanish-speaking. You can see how low they are when it comes to being in very good or good oral health compared to the rest of the people that were in this particular study. And this just shows where the highest concentration of our Hispanic population is along the border. This was from 2010. This was from 2000. I tried to find one from the 2010 census, and I couldn't. Maybe they haven't quite come up with it yet, but it's only bigger and better, I guess, than it was back then. But you can see where this is where our highest concentration of the Hispanic population is in the United States. And these are the dental health professional shortage areas in Texas. You can see where the blue ones are all along the border. And this is March 2011. And the reason this little section is pulled out is because that's the section that the Health Science Center from San Antonio targets. We're the Health Science Center for South Texas, and that's what's considered South Texas. These are the counties that we work with. The red one is Bexar County, where San Antonio is located. The rest are all along the border. The dentist to population ratios in South Texas, the border area has the lowest number of dentists per population, 16. This is per 100,000, okay? 16 to 1. And this is about half of the state's average, and it's less than a third of the national average. If you compare how many dentists per 100,000 there is in the nation, Texas is less than that. But then you look at the border, and you see the big difference. There's oral disease in Laredo, Texas, because we do a lot of outreach to Laredo. It's, 2 hours and 15 minutes from San Antonio. It's a hop, skip, and jump away, so we're there. We expanded some residency programs to the area, a pediatric dentistry residency program. So before doing that, we kind of did a little needs assessment of the area to find out whether or not there was need for our dental services to be provided there, because there's also some, there's not enough dentists, but we also needed to make sure that there was needs available that needed to be met, that needed to be addressed by our residents. And what we found there was that 30.8% of the population and 39.6% of the population live under the poverty level. That's a pretty big number. And they have the highest risk for caries. What Dr. Bobermoken found was that the general population in Laredo had a higher prevalence of dental caries, untreated caries, periodontal disease, and fewer dental visits in the past year than the national average. With the colonia program that we did, we went to 4 different colonias for an 18-month period, and we did screenings in order to prioritize treatment to make sure that the patients that needed the care the most were seen first. But these are the findings from the screening as we tabulated everything together. We had 38.3% that had a toothache at the time that we saw them for the screening. We had only 12.4% that had had a dental visit in the past year, whether it was for an emergency or comprehensive care. 63.8% had untreated caries. They had cavities that needed to be treated. 73.2% had a caries experience, and what that means is that they either had fillings or teeth extracted. In other words, at one point they had had a history of cavities. And then 68.2% had gum disease. So as we've talked about how oral health impacts general health and how the treatment of general health it affects the mouth, these numbers are staggering, and you can see where their general health is not good either. There's oral health disparities. Compared to other groups, Hispanics have lower socioeconomic status, more oral health problems, less oral health care. Many current federal initiatives are headed by HRSA to try and address some of this, but most of them target children, and they're short-lived. They don't stick around as long as they need to make sure that we take care of the problem. Efforts for new and improved initiatives are needed to address the reduction of oral health disparities. And in conclusion, general health therapy often has consequences that manifest and impact the oral tissues. Knowledge and education about their management can reduce the morbidities. If we learn about it, if we educate our patients about some of the things that can happen and how to better take care of, then that can decrease the morbidity of it. Oral health is linked to systemic health, so improved oral health can lead to improved systemic health. And then Hispanics have a higher prevalence of untreated oral disease, and access to dental care is a problem. We need to have initiatives to address and then prevention is key. If we can prevent the oral health problems or the general health problems, then we can prevent a lot of these. So that's it. Any questions?
Yes, I have a question. If you can go back to the slide where it says health, you had statistics, percentages on general health insurance and dental insurance.
Yeah. The one about Texas at the brink?
Yes. There, now. Is the third bullet for health insurance or dental?
Health.
That's health insurance.
Right. These were for health insurance.
Okay, and I know that.
Again, this is for people that are living in poverty. It's not for all the individuals. Of the people that live in poverty, 64% do not have insurance.
And I know that those that live in I know that those that are working need to have a health insurance and a dental insurance. That's separate.
That's separate, and many employers do not provide the dental, only the medical, because they have to. They don't have to provide dental.
And now, if you go to that slide where it was just really devastating to see the number of dental care available to the counties. So we don't have, we have a high pop record.
This one.
No,
Oh, the one before?
yeah, the next one.
Oh.
No, the before, I guess.
That
That one.
this one, the health professional shortage areas.
So we have a population that is
uninsured. And then we have also
Language barrier.
a population that is not even served by dentists. So where are they? Where are the dentists?
Well, they're there, but for the amount of population that is there, there's not enough of them.
Okay.
I mean, like some of these counties, for example, the whole county has one, and it's okay if you only have very few people living there. But for example, in Hidalgo County, Hidalgo, Cameron County and Webb County have had in the last, between the last census report, like 25, some counties have even had a 30% increase in population. You haven't had that kind of increase in number of dentists to the area, so it's only going to get worse. And some of them have had other dentists that have graduated and gone there, but if you add more dentists, but then the population is growing by that much, you still don't have enough.
Well, it's growing 10 times that.
And in that area, the population that's growing is, according to your statistics, the least served population anyway.
Correct.
Spanish-speaking Hispanics. And didn't you say that 40 out of the 254 counties in Texas had no dentists?
Oh, it's more than 40. I think it's like 46. I just didn't want to, I'm not sure. I know it's over 40.
So that's 20%.
Yeah, but some of them are like up there in the Panhandle or in West Texas. So some of them you think, well, it's okay because there's not that many cities or population in that. It's so rural that they're, but still, because you also have to think about, okay, if I'm going to open up an office, I need to have patients coming. And if there's only 10 families that live there, well, you can't have a dentist there. But, so you understand it in some cases, but not in all. It doesn't make sense. And down in for example, Zapata County has one dentist. And that's an hour from Laredo. It's between Laredo and McAllen. An hour each way, kind of, or 2 hours, But it's close to Roma and Rio Grande City, or Stark County and Zapata County are next to each other.
It's not a win-win situation here because you don't have access to...
Patients have to travel over an hour to go see a dentist if they're going to go see a pediatric dentist, if their child needs to see a pediatric dentist, because there isn't one there.
Most of the counties are underserved by physicians as well.
Right, right. Mm-hmm.
But you can always go to the emergency room. Are oral health provided in emergency rooms?
Yes, they are. They are. And that is a very common utilization for a toothache, to go to the emergency room, because if you think about it, one, you don't have dental insurance. Two, if you're working, you're not going to be able to take time off during the day. You're going to go after work, even if that means you spend the night there to get it taken care of, because you can't take time off work.
So who takes care of those patients because of oral?
For example, in San Antonio, we have the advanced general dentistry education residents that take call at the university hospital. And they're on call, and if somebody presents with a toothache, they're the ones that get called.
But you don't have any on faculty in emergency hospital, university hospital, or hospital?
We used to have a clinic in there, but we don't. Now, the university hospital and the dental school are close enough that the patient can always, if they need to be seen. I mean, I think physicians, for the most part, will take care of prescribing antibiotics and pain medication and then having them go somewhere else. But as far as getting clinical treatment to whether it's the extraction or the root canal or the cavity filled or something, sometimes they don't get it taken care of. They go from emergency to emergency because they can't take the time off work, or they can't save the tooth because they don't have time for more than one appointment, so just take it out. They just say, take it out. I don't have time. I can't come back more than once. I can't take time off work. They're uninsured, underemployed, right? So they have to hold on to the job they have.
And because of these, another question is, because of this linkage of systemic disease, which is most common in Hispanics, diabetes, and the oral findings, are y'all working with physicians? Are y'all working with endocrinologists?
Yes, I mean, and there are several studies that are also going on at the Health Science Center where we're looking at a lot of it deals with our diet because we have a high diabetic population, whether it's, implants, how they respond to therapy, how their hemoglobin A1C responds after dental therapy. There's a lot of that going on because we're trying to see how to best manage those patients.
Do you know if the physician, the endocrinologist, or the consulting physician refers or is mandatory that the patient sees the dentist?
That I wouldn't be able to tell you, because you have the medical clinic and the dental clinic that are separate. I don't know that there's where you have that exact working relationship is at community health centers. I used to work at a community health center. You treat the whole individual. Patients that were diabetic were sent to the dentist, to the dental clinic for an evaluation and at a minimum to have their teeth extracted that needed to be extracted and to have their teeth cleaned, because those were the things that were going to decrease inflammation. If you were pregnant, you were referred to the dentist because gingival inflammation we wanted to get that bacteria out of there, and then any other non-urgent care could be taken care of after you had the baby. So that's where you have that team approach. Now, we are going to be having a new dental clinic that's going to be built right next to the Mark in San Antonio, hopefully by 2015. And because they're going to be right next to each other, hopefully that type of relationship will be working out. And I guess it's after one.
This is it. Thank you so much, Dr.
Okay.